Good afternoon, and thank you for the opportunity to speak to you all about eliminating vertical HIV transmission. And as so many of you have been speaking so far this week, this reflects decades of work that has gone into taking us to where we are, and I have nothing to disclose. And the question we must ask ourselves is, are we there yet? And this slide has been used by several presenters over the year, and I find myself using it again. Are we there yet? And as my colleague Dr. Mugoidi said, when you talk about a journey, it's important to look at where you're coming from. Well, today we're actually going to start by looking where we're going. And what is our target destination? Where do we hope to get to? And the target is to have 0 new infections among infants and young children, and achievement of the 95, 95, 95 targets. And with respect to mothers and children, that is at least 95% of pregnant women attend at least one antenatal clinic visit and have an HIV test. And then for those who have HIV, at least 95% of the pregnant women access ART. So that's where we're heading. But progress in reducing new HIV infections among children has stalled. There were 160,000 children under 5 newly infected with HIV in 2021, despite significant gains in the last 10 years. The percent of pregnant women living with HIV receiving lifelong ART did increase, but we missed the target by 2020. The vertical transmission rate dropped almost by half, which was tremendous success. But once again, we missed the 2020 target, which in breastfeeding countries was to have less than 5% vertical HIV transmission rate. So clearly, the current program doesn't serve all mothers who could benefit. There are implementation scientists, many of you here in the room, who work tirelessly to improve uptake and impact of the current standard of care, but gaps still remain. So much so that about 70% of new HIV infections among children arise from scenarios where the EMTCT program wasn't fully delivered. That is, the mother was not on ART or had dropped off. Those are represented by the yellow and grey bars in the stacked bar chart on the right of your screen. About 20% of childhood infections arose from a mother who had acquired HIV while pregnant or breastfeeding, shown by the brown and pink stacked bars in the graph. And about 10% of children, the mother was on ART. And those are shown by the blue squares called out on the stacked bars. So you can see more than 50% of women are booking their ANC on ART, receiving the treatment. And they are generating about 10% of infants with HIV. But the vast majority are coming from women who are not on ART, where we failed to deliver the program. So inequalities affect the success of the current standard of care. And as we've heard from other speakers, putting women at the center of all of our programming is the way to go. Pregnant and breastfeeding women need HIV treatment and prevention options that suit their circumstances, that can be delivered in HIV high-burden countries, and that overcome the multiple social and structural barriers that they have to navigate for successful health outcomes. So this framework, which is in the Global AIDS Strategy 21 to 2026, focuses on priority areas. Firstly, improving access to the services that we have. Importantly, breaking down barriers. I'll call out stigma, discrimination, and gender inequality that are particularly pertinent for pregnant women and children. And also importantly, to make sure that we invest We fund and sustain the programs and the health workers that deliver them. So, yes, we've made progress, we're on our way, we're not there yet, and we seem to be stuck. Like that roundabout we have just outside the hotel. We've been going round and around and around for about 5 to 10 years, and we're not managing to negotiate the exit. What is it going to take to get us out of the roundabout and off, steaming ahead towards our target? So firstly, we can do better at what we already have. And I would say we should begin by prioritizing access to HIV prevention services for women in general, but especially during pregnancy. New HIV infections in pregnant and breastfeeding women increase the risk of vertical transmission, so targeting that population specifically comes with at least a double dividend, if not more. There is an increased risk of HIV acquisition during the pregnancy and perinatal area, and luckily we do have pretty good data about the TDF-FTC oral PrEP in terms of its PK and safety. There are encouraging safety data for its use in pregnancy. The PK benchmarks have been established. Sadly, uptake and persistence is low in general, but also in pregnancy. And adherence to that PrEP may be particularly challenging in the perinatal period. There are good data, for example, down on the bottom right, which shows that only 7% of the women who took PrEP during pregnancy had drug levels high enough to indicate they had taken 7 doses a week, which is thought to be the coverage required for effectiveness. Secondly, and probably more importantly, we need to prioritize access to quality reproductive health services. Unplanned pregnancies increase the risk of vertical transmission and also poor pregnancy outcomes. So there is an increased risk of preterm delivery in women with HIV. Contraceptive services help support planned pregnancy for women with HIV. That gives us a chance to manage viral loads and optimize outcomes after delivery. In terms of maternal, newborn, and child health services, that's often the first contact that many women have with HIV testing. Booking early for antenatal care ensures access to HIV testing and ART or PrEP, whichever is relevant at that time. It gives us adequate time on ART to achieve viral suppression before the labor and delivery period, which is the time of greatest risk for vertical transmission. Booking early also gives us an opportunity to monitor the maternal viral load and for common complications of pregnancy. Thirdly, we need to optimize the use of safe and efficacious ART during pregnancy and while breastfeeding for women who do have HIV. The elevated maternal viral load is the primary risk factor driving HIV vertical transmission, and this needs to be managed. One study I'll call out is the Impact 2010 study, which showed that more than 90% of women had a viral load less than 200 copies per mil by time of delivery, which was a tremendous success. Those women enrolled in the second trimester of pregnancy. Looking at the different regimens studied in that study, the dolutegravir ART regimen, which is now our first line, was superior to the efavirenz ART regimen. In terms of time to viral suppression, which was quicker, viral suppression being more likely at delivery, and also less virologic failure. These findings were supported by multiple studies. Another is the Dolphin-2, which enrolled women a little bit later in the third trimester of pregnancy, and still the suppression on dolutegravir was superior to that seen on efavirenz. I'll call out the time to viral load less than 50 copies per mil. As you can see in the dolutegravir ART arms was 4 weeks, compared to 12 weeks with efavirenz. So these drugs are safe, they work very well, and they work quickly if they are taken and the woman has access to them. good news is that infants of pregnant women on effective ART have a very low chance of acquiring HIV. The maternal viral load must be suppressed throughout pregnancy and breastfeeding, and I believe that suppression does not mean 1,000 copies per mil. It can go and should go much lower than that. Let's aim for it being undetectable as opposed to less than 1,000. Again, from the 2010 study, there were 4 infants who had HIV by the time of exit at 50 weeks post-delivery, and some details of those 4 babies. The first on the left was diagnosed within 14 days of life, and some details about the mother's viral load that had been high during her pregnancy. The second child was diagnosed at 6 weeks of life. The mother's viral load had been below 50 copies per mil following 8 weeks on treatment, so her viral load was not high. The third baby was diagnosed within 14 days of life, and the highest viral load the mother had had after 8 weeks on treatment was 42 copies. And the last baby was only diagnosed at 50 weeks of age. And in that case, the mother's viral load had been greater than 40 through postpartum week 26. So very few, very isolated transmissions, but all of them with quite interesting stories. Achieving sustained viral load suppression on daily oral ART can be challenging, and this could be more challenging postpartum for very many reasons. Some of those challenges pertain to ART adherence itself at the individual level, and what we are told about missing doses for infants in red and mothers in blue from that chart is that they were mostly due to pill fatigue, poor mental health, forgetting the tablets, especially during travel, not having food to eat before dosing, and competing priorities. Well, I don't know about you in the room, but having a newborn baby in the house, I would call that a competing priority, right? It can be a hectic time in any family. Societal reasons often revolve around non-disclosure of HIV status, primarily to the male partners or other relatives. And once again, we call out stigma and gender inequality. Let's break down those barriers. Looking at service delivery challenges, logistics like commodities stocking out, as well as health workers being overwhelmed and demotivated. Let's fund and sustain, make sure that our health systems are strong and able to deliver quality care. So another thing we should do is prioritize maternal viral load monitoring for both mothers' health, as well as being able to deliver risk-based infant prophylaxis. So infants of mothers with high viral loads are often given more ARVs as a safety net. More ARVs can be given for longer periods, for example, to babies with mums who have a high viral load or have only been on ART for a short duration, or in mothers newly diagnosed with HIV. But access to viral load testing is erratic in many of our settings, and there are various workaround approaches to, for example, seatbelt all the babies for a safe journey, such as giving 3 ARV prophylaxis regimens to all babies, regardless of their risk profile, or giving infants ARVs throughout breastfeeding. So there are different approaches there. But I would say let's focus on getting access to viral loads. If you can only do one, I would say let's do one at 6 weeks postpartum. We have data there from Zambia and Burkina Faso that showed that more than half of the mothers with a high viral load at 6 weeks postpartum also had a high viral load later on at 6 months and or 12 months postpartum. So that is a crucial point that may help you pull out mothers needing particular care and focus. The same group also showed that extended infant prophylaxis, guided by point of care maternal viral load, reduces the time they spend exposed to risk while breastfeeding. Point of care viral load supports timely decisions for the mother's ART and the infant's prophylaxis. So at that 6-week postnatal review, A viral load for the mother can help you decide whether to extend prophylaxis if she's not suppressed, and then repeat it again at 6 and 12 months. Doing that will allow us to reduce the time they spend exposed to a high viral load in the mother's breast milk. But real-world outcomes fall far short of these successes that we report in our published studies. The clinical trial environments are rigorously controlled to overcome those implementation barriers. If we look at observational cohorts, for example, this one from Tanzania, the standard of care was delivered and they observed the health outcomes in mothers and babies. About 40% of the data had to be excluded because they had incomplete data from the standard of care routine data collection, and that is normal in most of our settings. The vertical transmission that was recorded was 1.4%. Now, isn't that a success? 1.4% was more likely if the woman started ART late in pregnancy, if her CD4 count was low, if she was on second-line ART, and if it was a low-volume clinic. 1.8% transmission in mothers initiating treatment in ANC, but half of that, 0.9%, if the woman was already on ART prior to pregnancy. So that's a great success. But when you look at national figures, 8 times higher, 11.1% outside of that setting. And that reminds us again that there are these priorities to improve access, break down the barriers to access and persistence, fund and sustain the health systems to make sure we deliver. So what else will move us off the roundabout? I have a few minutes left just to brush very superficially into what might be on the horizon. So, earlier inclusion of pregnant women in new product development. It's beginning to happen. Shout out to all the regulators and the funders in the room. Thank you. Long-acting products could overcome some of these challenges with daily oral dosing, and we're still to optimize implementation in women, and especially in pregnant women. But we're beginning to get some of those answers. These products have been mentioned and will be mentioned again by other speakers. Destigmatizing and discreet, those are the catchwords. But we do not know the experiences and preferences, periconception through breastfeeding cessation, those are yet to be described. There are multiple implementation questions, how to deliver quality integrated services. But also, we do have some data coming through from PK and safety studies. For example, this one, there are inadequate PK and safety data for us to allow these products to be registered yet, but they're coming through. In short, modeling of the long-acting cabotegravir rilpivirine injectable treatment predicts a decreased plasma levels during pregnancy, which is what we expect and what we commonly find with many ARVs. There are ongoing studies to collect safety and PK data for the long-acting ARVs during pregnancy. For example, the IMPACT 2040 protocol is studying cabotegravir rilpivirine in women with HIV. The HPTN-084 protocol has a pregnancy and infant sub-study underway for cabotegravir injectable as PrEP, and the dapivirine vaginal ring has a duet of studies that are categorizing safety and PK. So far, no safety concerns for mother, pregnancy outcome, or baby. Lastly, infant postnatal prophylaxis with broadly neutralizing antibodies is under study. BNABs have distinct advantages for postnatal prophylaxis. There is a precedent for this technology for other perinatally transmitted viruses, for example, hepatitis B. End user acceptability for the other viruses has already been established. The long-acting product does mitigate some of the challenges with adherence that we mentioned, and with BNABs, as opposed to giving ARVs to the babies, it avoids resistance to future ART regimens, which is a big issue for pediatric treatment. There is a possible risk for infants who do acquire HIV despite the ARV prophylaxis to develop resistance, and that limits our treatment choices even further. BNABs have favorable PK and safety profile. They achieve the systemic target levels rapidly, and the PK is not affected as the baby's physiology matures. So we're almost there. We're getting closer. And now hepatitis B and syphilis programs are hitching a ride. And they now no longer are aiming only to eliminate HIV, but also hepatitis B and syphilis. We aim to have 0 new infections among infants and children and achieve the 95-95-95 targets. But I want to end by saying that we shouldn't be focusing again as this negative. We want this gain positive view. The Triple EMTCT initiative focuses on a harmonized approach to what? Improving health outcomes for mothers and children, not just eliminating a disease. Let's focus on improving health outcomes. I would like to acknowledge all the families and communities involved for their tremendous courage and dedication over the last 30-something years of trying to eliminate pediatric HIV, as well as the research networks, regulators, drug manufacturers, sponsors. Many of us come together regularly as technical working groups to work in this particular population. With that, my thanks.